Welcome back to this slightly different episode of Sharp Scratch. If you listened to our last episode where we chatted to Dr. Mary Miller, a consultant in palliative medicine, you'll recognise the three people that we have on. If you haven't listened to that episode, it might be worth going back and having a listen before you hop onto this one. So firstly, I'd like to reintroduce our two panel members for the episode, Éabha and Mary. Could you introduce yourselves, please?
Hi George, great to be back. My name's Éabha and I am a fourth year medical student at Lancaster in the Northwest. I'm just finishing off the academic year on my medicine placement at the minute.
And hi George, my name's Mary. I'm a final year medical student at the moment. I'm just finishing off my assistantship block. So I've got a couple of months left and then I'll be qualified, which is really exciting.
Amazing. I'm so happy to have you both with us. And I'd also like to welcome today's expert guest, who of course you'll have met before if you listened last time, Dr. Mary Miller. Could you introduce yourself to us as well, please?
Hello. Hi, George. Thank you for the invitation to return. I'm Mary Miller. I'm a consultant in palliative medicine based in Oxford and have had the great pleasure of spending about half my life in the UK working in palliative medicine.
Amazing. Thank you so much. I'm so happy to have the three of you back for this episode. So in the last episode, we spoke to Dr. Miller about your career in palliative medicine and what drew you to a career in palliative medicine. In this episode, Dr. Miller, we want to ask you some of the questions that we felt were raised that we didn't feel we could ask in our kind of end-of-life blocks while at medical school, or that came up for us while thinking about this episode. And some of these questions have been things that I've sat down and spoken to medics about over the past week while I was preparing. I'm going to start with a question that I've wanted to ask. And I'm hoping that this is actually an experience that some people have. But one of the things that came up for me was that there are people who are quite fearful of their own mortality, of death and dying. And I think that being a medical student sometimes, and being a doctor, changes your relationship with your own mortality and the way that you think about your own death. But hypothetically, if there were to be a medical student who felt a bit fearful around these topics, is that normal? Is that something that you've come across, Dr. Miller, where people are a little bit afraid of these conversations about death and dying?
Absolutely. And in that, as doctors, we are first and foremost human beings, and also we are witnesses and bystanders to a lot of different types of death. So I think it is completely understandable that for some of us, we'll find this a difficult thing to see and a difficult thing to be around. In terms of thinking about how you address that as a doctor, I think it is getting to know yourself and understanding which areas of medicine you find easier and which areas of medicine you find harder, because you may decide that this is something that you would want to do fully, as I did, a career in palliative medicine, or something that you want to avoid. And I think that for me, I found out by doing a year or two in palliative medicine before making a decision to choose that as a career, because it took me that long to decide whether this was something I could do as my work every day for the next 100 years.
Yeah, I've got a palliative care job in F2. So I'd quite like to know, for people who are in my position who are maybe going into jobs where they have palliative care rotations, if there's things that you think we can be doing either as medical students or in the lead up to those jobs, which can support us and help us to be better when we start or to look after ourselves better. Anything you would suggest that we start doing now to prepare ourselves for that role?
Yeah, thank you. Great question, Mary. This may be my learning style, but in doubt, I will read if I don't know what to do. So I think that there are some fantastic books out there that actually help me improve my communication skills, even having done it for some years. I'm thinking particularly of Kath Mannix's books, which I love, and also thinking of a new book by Sammy Winemaker that's talking about hoping for the best and planning for the rest. And I think it's just a really helpful way to have some phrases that you can borrow that help your communication style. So I do some prep in terms of general reading around death and dying, if that is not too morbid. And then I think as I'm approaching my palliative care placement in F2, delighted it's in F2. You'll feel more confident in your medicine in general. And secondly, I think I would be thinking about my supports and who's around me as I start this job. And I would expect, having watched myself and many, many doctors and medical students come to palliative care, that there's a bit of a honeymoon phase where you think, great, this is the best job I've done. Alternatively, you might walk in the door and think, I hate this. But there is a bit of a honeymoon phase, I think, of thinking this is a lovely job. I remember why I wanted to do medicine. And then sort of 2 to 4 weeks in, depending on your placement, where the patients that you've admitted, that you've got to know, are beginning to die. There's a hard bit you hit. And I think that's when you need your supports. So I would recognize that that's coming and that you can prepare yourself to some extent. My supports are in place, and I would grit my teeth through a few weeks of that because it is hard. But you do get to a place where you begin to rebalance, or at least certainly that's what I've watched others and I found I've done. So I think that's what I would do to prepare. 3 things really: a bit of reading, supports in place, and recognize that you're going to hit a bit of a bad patch when the patients that you've got close to begin to die.
That's really helpful advice. Thank you very much.
So, Dr. Miller, one of the things I was going to ask you kind of leads off of Mary's question, but one of the things I found as a medical student that is difficult is knowing what your coping strategies are for when you have a bad day. Have you put in specific coping strategies to help yourself?
Ashley, thanks, George. There's what I should do and what I do.
Yeah.
But leaving that to one side, I think we know medicine's hard, don't we? Look, doctors have higher alcoholic rates, etc. So we know this is a hard job, and it's hard in palliative medicine, it's hard in many other branches of medicine. I think I would borrow something from Sammy Winemaker's book, which is about what has helped you in tough times in your life, because that's probably a good guide for what works well for you. So, for instance, if you've had, as all of us will have, difficult times, breakups, family illnesses, etc., what has been dysfunctional? Don't do that. What has been functional in terms of helping us? And for some, that'll be exercise. For some, it'll be movies and friends, etc. So I think it's looking back and thinking, okay, I already know what works to some extent in my life. I'm going to put that in place. And that's perhaps a good place to start. For those who've had blessed lives, who arrive at their palliative medicine placement, and this is the first time that they've found that patients have died, and this has been really tough, I think that I would go to what you enjoy doing outside work as a good way to rebalance work.
Dr. Miller, I know we talked about it a little bit kind of in the previous episode, but when so much of the focus of medical school and the medical curriculum, like George, I know you mentioned you had a week in a hospice, I had too, when so much of our medical school kind of journeys is about fixing diseases and curing illness, how to get used to the kind of the palliative care, person-centered, symptom management, quality of life, what matters to your kind of mindset. But I was just wondering if you had any kind of advice to students who are maybe a bit apprehensive about such a difference in environment, such a difference in kind of objectives.
I have a couple of thoughts, Éabha. First is that we are doing ourselves as doctors and as medical students a disservice. Because if you look at the people who are in our hospitals, and you today walk into any hospital in the country, 10% of the people in the inpatient beds are going to die during this admission. 25 to 30% will be dead in a year. So actually, now modern medicine is looking after heaps of end-of-life care. And we are not equipping people to actually be able to provide that care, in my view. So given that the world is the way it is, and that there's so much to learn in medicine, and a bit like learning about normal physiology before you learn pathology, perhaps we need to learn about the wonders that modern medicine can achieve, and then actually recognizing that so many people are dying in our hospitals, and that the complexity as people approach the end of their lives is huge. So given we can't change all that, then it's thinking about how do we gather the skills to actually work in this space? And I think the first thing is to remain kind and human in the face, perhaps, of feeling de-skilled when we're walking into a room to look after those who are dying in their family who are around the bed. So I think in the face of lack of skills, it's thinking about who are your allies around you. If you're in a hospital or you're in general practice, where's the palliative care team? And I hope that nobody is ever on the receiving end of that wasn't complex enough from a palliative care team, because actually the person who brings you the problem, if they don't know what to do with it, that's your bag as a palliative care doctor or nurse. So know where to escalate and who to get help from. And you'll know that from your own teams, some of whom you care, the elderly physicians do lots of end-of-life care, are very good at it. It may be that you are, as your F1 job is in a surgical unit where all the seniors are in theatre the whole time and there's not much help. So who are the nurses on the ward who are good at end-of-life care? Where's the palliative care team? How can you get help? As you're beginning to walk into a palliative care placement, in terms of thinking about how do you prepare yourself for looking after this patient group, I think I will be asking the people that you're going to, is there any text that I should have? And much like most of us had, in my day, the Oxford Handbook in our white coats, I think actually knowing where there's a couple of online books or textbooks that you can go to look things up. I think doctors are better with information.
Is there anything that you appreciate from your medical students? Anything that they do or any way that they behave that you notice and appreciate?
And nobody's ever asked me that before. So that is a superb question. I think curiosity about the person who's sitting in front of them. And I really appreciate people being present. Sometimes the conversation may feel routine to us as doctors. It probably does not to the person we're talking to. They may be checking out facts. They may be having a second opinion. It may be the first time they've asked really important things. So I think being present and non-verbally demonstrating listening, looking at the person, not, me included, not worrying about the text message that just pinged on my phone, etc., being present. So curiosity about the human being and being present.
I know the point of this was to ask you questions, Dr. Miller, but I want to kind of flip that question and ask Mary and Éabha, like, what do you find is like good teaching on things like this? Like, what do you like from, I'm not saying, well, hopefully there might be some people who are listeners of Sharp Scratch who actually teach medical students, but what do you appreciate from people who are teaching you in those kind of scenarios? Because I think it's got me reflecting on like what I have found to be like good teaching and what has resonated for me. But like, what would you want from the flip side, if that makes sense?
I think for me, the first thing is probably that if we've just seen something really difficult, I know it seems like a really small thing, but just checking in to make sure that the medical students are actually okay. Just because I think no matter how good the teaching is, if you've just seen something really, really challenging and you're not okay, then actually it doesn't matter how good the quality of teaching is, none of it is going to be going in anyway. So for me, I think the number one thing is like taking a moment away from the situation and maybe taking time to explore like any emotions around it if you have the chance before you then go into the teaching, which I know like in my experience most of the time that does happen, but I don't know if that's universal. So yeah, that would be my main thing, is just actually kind of well-being checks when you're working in quite a challenging environment emotionally.
Completely agree. And just because I'm used to those conversations and going from one to another does not mean that as medical students or as resident doctors, foundation year doctors, that people are used to them. You're absolutely right, Mary.
Exactly. I think sometimes on placement, yeah, because people do things every single day, and same as medical students, we do things every day, so we forget that it's not normal for a lot of the population to be seeing things or doing certain things. But yeah, that could be the first time that medical students ever interacted with a patient who's coming towards the end of their life. So I think acknowledgement of that is, yeah, for me the most important thing, but I don't know if Éabha would agree.
I definitely echo that. And I think maybe it's just my experience, but I think that was something that my palliative care kind of placement team were very good at, in comparison with some teams in the hospital that maybe are less kind of aware of how new it is, because there are things in the hospital that I have found just as, if not more distressing than the things that I saw in the hospice. For me, the thing that makes really excellent teaching, you touched on it in the previous episode, Dr. Miller, was modeling very good practice is a huge thing. Like when you see a doctor patient interaction and you're like, I want to be like you someday, like I hope I can handle conversations the way that you have, is probably the most helpful thing. And I think especially when it comes to things like end of life care, where I know that you said earlier that like it's not the words that you use, but I think sometimes when you learn kind of good words to use and how positive a different words can make, I find that very kind of reassuring, but also very helpful. And I also think kind of above all of that, though, it all kind of fits under the same umbrella, is being included in the team and being considered a part of the team. The thing that I guess defined my hospice placement was that I was only there for 2 weeks and everyone I worked with knew my name. And that's so rare, but it makes such a huge difference to my placement. It wouldn't be like, I'm Doctor so and so, that's the student. It was like, my name's so and so, I'm the doctor, and this is the medical student Éabha who's working with me today. And I think when you're included in the team, even though you're only there for a short period of time, and you're included in the team in those patient interactions, and you're included in the team in MDT meetings, etc., it really made me feel less of a spare wheel. Like my being there, my presence was kind of worth something. And I think because of that, I learned a lot about the kind of doctor that I want to be and the kind of work environment I want to curate for my juniors someday. There's loads and loads and loads, I think, that makes good teaching. And it's often not just the didactic, what you're actually being taught, it's how you're being treated.
Yeah, I agree with you. And I think like one of the best experiences that I had was when I was in a clinic and someone had to deliver some news, but then afterwards the patient left the room, the consultant said that was really tough. I think we should all take a minute. And actually just hearing them say that was really tough kind of really validated how I felt, because I was feeling really like that was really difficult to listen to. Like the patient was really upset. I was quite upset but as soon as the consultant said that was really, really challenging, all of a sudden it was like you were almost given permission to actually feel sad. And the stress of the fact that you were worried about feeling sad went away, because it's like, no, actually you are allowed to be sad about that.
And it's so reassuring, isn't it, when it's somebody who's senior to you in the hospital hierarchy or the hierarchy of where we are as medics says, oh, I found that tough. I think as a student or as an F1, like hearing somebody else say that was really tough, I'm going to take 5 minutes. And I had like a similar experience when not as a medical student, but I used to work in a rehab hospital and I had like a really difficult interaction with a patient who was really, really upset. And I came out of this patient's room after this 10 minutes, which was really intense. And the physio was outside and said to me, right, now let's go have a cup of tea and we can kind of debrief. And for me, having that interaction of, okay, someone else also found that really tough made me feel like validated in my feelings and also made that person more approachable to me for me to go in future and say that was something I found difficult or whatever. And I think facilitating those conversations and as you say, Éabha, it's difficult because we're often in a place for such a short space of time. It's difficult to feel integrated and part of the team, but I do think that there are ways that as medical students and also as people teaching us, we can facilitate bridging that gap and making us feel more like team players.
Can I add, George, that we own the skills to get to know patients and their families pretty speedily, and that it is really important to deploy those skills into looking after our colleagues, because actually we own them. So it's important not to get so beaten down and exhausted that we forget to look after those around us.
That's so true. And we've spoken a little bit about like compassion fatigue in episodes before, but I think that's so true. Is actually we have the skills and we share that empathy for our patients. So why not also share that with our colleagues? Éabha, I can see you nodding.
I think about that all the time. And we've come back to it and back to it and back to it in this episode. But when I just think about the doctor that I want to be, it was when I was on my hospice placement, something like the team had received quite heavy news the previous night before, and we were walking into handover the next morning, and the doctor was like, is everyone okay? Is everyone feeling okay this morning? In the same way that you would if it was a patient, you wouldn't hesitate to ask a patient that. But it was so exceptional that I saw a doctor ask the team that I was like, I want to be that doctor when I grow up.
I have a question that is selfish, and I've wanted to ask this for a long time. Dr. Miller, do you think that medical students can be part of like holistic care and a holistic environment for patients who are at the end of their life? Are medical students, can they be a part of that dynamic, that team environment that is providing holistic care? Because I think sometimes as medical students, like Éabha, you said earlier, like feeling a bit like a spare part and things like that. But actually, is our presence in some of these spaces and conversations a good thing, or is it a neutral thing? I think is what I'm trying to ask, really.
Do you know, I don't think that occurred to me when I was a medical student. Looking back now, I think that you are part of the holistic environment. I would feel confident in walking into that space. I think that the patients and their families, they may ask you questions that you do or do not know the answer to, but I think they will understand that you may need to hand that on to the team and the doctors. I think the things that you own that perhaps get beaten out of us as foundation doctors and as resident doctors to start with, and that we come true and regain. But it is well documented in the literature that medical students retain their humanity and lose it a weeny bit when, you just don't get enough sleep and life is very busy. And I think it comes back as you move on and you've got over that enormous hump of learning how to do this job when you're responsible for its delivery. But I think there are oceans of things that you can do at the bedside. I think checking back on the patients, as we were talking about in the last episode, I think if it's a really tricky conversation the patient has just had and you have time and it's okay with the team, I think even organising for somebody to have a cup of tea, you don't need to make it, but just asking that somebody has a cup of tea brought to them. I think there will be patients who are dying alone or who are sick alone, whose families can't be at the bedside at that point in time. And I'm sure you have oceans to do, but you may have 5 or 10 minutes just to sit by somebody's bed. I remember vividly 2 medical students in the hospice here who remain in my memory. The first, I don't mean this to be gendered, but there was one of the girls who, I remember her brushing one of the patient's hair one day. And for some reason, she had felt that the patient's dignity would be supported by having brushed hair as opposed to, all over the place, bird's nest type hair. I remember her doing that, and I remember feeling privileged to watch that, because actually most of us had attended to symptoms and yada yada, but hadn't thought about what was important to this lady. And the lady's daughter walked in and said she would be so pleased because her hair was always beautifully sorted out. And the second was one of the medical students who was here on their post-qualification placement. They were here for 2 weeks and they had got to know this patient, and this patient loved poetry. And they were now semi-conscious stroke unconscious. And I found that young man sitting by the patient's bed reading poetry from the patient's book that he loved. So I think that it's not to say you have more time. You don't. You have very busy, your exams to pass and things to do. But actually taking moments and remembering to take those moments. So I think that in terms of the holistic care and remembering that the patient in the bed is a person, that you have a very important role to play. And the other things we talked about earlier, presence at the conversations, asking questions. If you think that actually the patient said something important and the whole team just walked away from that particular statement or didn't ask enough questions about it. So I think contributing to the ward rounds, saying the patient raised that, I just wondered where it was in your thinking,
Yeah, I think that was really amazing. And I think what the listeners won't have seen is the look on all of our faces when you told those stories. And for me, like, it's really powerful hearing things like that, because I think that's really like medicine. Like, I think that's actual medicine. And I know that time is like a privilege and difficult to come by, especially for those of us, working in the NHS. We know that, we acknowledge that. But actually, what you said really spoke to me, because that's not something that we often speak about as medical students, as being part of that kind of therapeutic dynamic that we have sometimes with patients, but like listening or giving a bit of compassion or giving a little bit of time. is really powerful. I feel quite taken aback. I think that's quite an interesting thing to hear. And the fact that those are things that stood out to you, it's not the medical students who like answered your questions and got all the questions right, or, but it's actually seeing people as human and giving people that time is incredible. Yeah, sorry, Dr. Miller, go on.
Just, of course, we need to be competent as doctors. We also need to remember how to be, caring and compassionate.
I also, just before we move on from that point, want to add that it's like the privilege goes both ways. Like, I am literally a 23-year-old girl off the street, and to be able to share in people's like last days is not something I take for granted, and I'm sure it's not something that most medical students will take for granted. And like, that is a real privilege that I am so grateful to have had and have been trusted with. So that goes both ways. I'm sure those medical students that you were talking about, like, I'm sure they appreciated it as much, if not more, than you did.
Absolutely. And you haven't asked me, but I would do palliative medicine again tomorrow morning. And it has been for what you said, Éabha, which is the continual learning experience that this career has been. I would not be the person I am today if I hadn't walked that path with so many patients and their families and thought about what they said to me and what I saw.
I had a question about consenting medical students to be in consultations and things like that. How well patients can be consented to having medical students present in kind of breaking bad news consultations if they don't necessarily know the news is going to come, and then what we can do in those situations to make them feel more comfortable with us being there if there's ever a situation where we potentially should leave. Or I don't know what your thoughts are around that.
Thank you. That's a really important point, isn't it? That actually we're asking people's permission and they don't know exactly what's going to take place in the consultation. The fact that you even asked that, Mary, I think takes you most of the way there. But I guess, as we might do in our home lives, if you feel I am uncertain about my presence in this situation, a conversation where you feel I'm not certain I should be listening to this. I think it's looking for that tiny space in the conversation and asking, is it okay I'm here? If you think, well, I'm misplaced. It's rare I ask that now, but when I do, and sometimes it might happen about matters of spirituality or something like that, where somebody's talking with a chaplain and they're talking about perhaps their existential fears, and I think, oh, goodness me, should I be here? It is extremely rare that a patient says, yes, please leave, in the politest possible way. It's rare. I think patients are fully in the flow of what they're talking about. And I think you're right. I think we're not fully consenting people. I think what we're saying is, and my language about it isn't about consent. It's about, this person is training to be a doctor. Would you mind if they sat in on the consultation? I hope it will help their skills looking after you and other patients in the future, and sort of leaving it pretty broad because they don't know what they're agreeing to. I think you're absolutely right about that. And just raising your voice if you think I'm misplaced.
Yeah, that's really helpful. Thank you. Because I think sometimes, especially, we talked earlier about hierarchy, and I think in situations where maybe there's not as much of a hierarchy feeling, then it's easier to step up, right, and say, actually, I'm not sure if this is quite the right thing. But I think if you feel like there is a big hierarchy in your organization, then that can be more difficult. But yeah, I guess like we were saying about establishing yourself in a team and things before makes those kind of situations a lot more easy to deal with.
Absolutely. Absolutely. Yeah.
I have two more questions. My first question is, and this is a really selfish question, because I have a little bit of a morbid sense of humor, and sometimes I think I use humor as a bit of a coping mechanism. Is that okay? Is it okay to find humor in some of these things that people might say, well, that's not appropriate to find a bit of humor? But sometimes even you'll have conversations with patients and they'll make a joke, and you kind of have to assess with the individual patient. You definitely know the patients where, okay, this isn't the time and the place, but sometimes a patient will make a joke about their own death or their own illness. And, is it okay to find humor in some of these things that are really heavy topics?
I think it's very useful coping strategy. And I think that one of the comments that the volunteers, the families, the patients make about the hospice inpatient ward is that there is so much laughter around the place. And I think that's true. There's also oceans of tears and distress. But I think that laughter is a really good way of just taking the steam out of a situation and the heat out of a really tricky encounter. And I think it diffuses the situation nicely. As you said, there's a time and a place. And I think that's why doctors make good comedians, is that actually we turn tricky situations we find ourselves into, and there's humor to be found in them. So I don't think it's inappropriate. I think that it is harder to find spaces in hospital that are private to let off that kind of a steam. The one advantage of having a private canteen for the healthcare staff was that it allowed the staff to de-escalate a bit of the tension of the day. And I think messes and things perform the same sort of function. But our spaces in our hospital are being eroded for patients and their families. I think they're also being eroded for the staff. And it is harder to find spaces where it's okay to joke about things. Perfectly okay.
I think that's another podcast episode about spaces for staff to decompress. I hadn't thought about that, but I completely see that.
So I was wondering, when you talk to members of the public who aren't medical about your job, and when you explain to them what you do, what kind of reactions you get, and how you go about explaining to them what your job role is. Because I feel like that's something we don't really talk about very much as doctors, but often when you tell someone you're a doctor, their reaction is different to obviously your other doctor friends. So yeah, how do you go about explaining palliative care to them?
So apologies to members of the public. It drives me nuts when people go, "You're so good." Because I think, yeah, no, I'm an ordinary human being. That's the most common reaction. So it'll then vary. So you're so good to do what you do. It'll vary from being appalled and people move away and don't talk to you at the party anymore, which is fine. Or they will actually want to tell you all the people who've died belonging to them stories and what people did good and bad. So it depends how tolerant I'm feeling, whether I will sit with those stories. In terms of how do I explain my job, I think that's a really interesting question. It varies by culture. I don't take that many taxis, but I will occasionally be in a taxi where I'll be talking to somebody about my job and we'll be having a discussion about, the people they know who died and what didn't. And then I may be talking to another person who may come from a different culture who will not want to talk about death and dying and think my job is beyond weird and why is there a specialty that does this? So I think what I have learned to do is to be very careful about the context into which I'm speaking. Now, I'm making some assumptions from the people who are picking me up in the taxis about their culture, but I am more careful with some cultures than others. Ireland's easy because I think that people still are happy to, going to funerals is a bit of a national sport. So it is easier to talk about my job in Ireland than it is in the UK. And it is much easier to talk about my job in the UK than it might be in some countries around the world. So how do I explain it to people and tell them what they're doing? So I think I would start by saying that as people are approaching the end of their lives, that people have symptoms that it is my job to help them manage. And then I also am trying to help the people live as well as they can while knowing that they're going to die of this disease and support their family. And then I stop talking because for the most part, I find that members of the public don't particularly want an essay on palliative medicine. I'd be happy to talk about it for hours, but I just try and keep it relatively brief and then respond. Annoyingly, I feel it's my job to encourage conversations about death and dying. So therefore, I do not tell people I do other jobs. I tell them I do palliative medicine and I try to have a bit of a conversation about death and dying with people. And if I think somebody is very, very uncomfortable, I might ask them, have you made your will? Knowing that 70% of the UK population have not. So I might just say, but we never know what happens, do we? It could be knocked down by the bus we're just passing, etc. So I think that part of the public health approach to palliative medicine is encouraging conversations, but I try to do that respectfully because I know nothing about the person's life that I'm speaking to. I've had no notes to read. I've had nothing at all. So I'm being reasonably careful about the context into which I'm speaking.
My last question for you, Dr. Miller, is what do you like about working in palliative medicine? For somebody listening to this who thinks, actually, this has kind of piqued my interest, I might be interested in a job in this. What do you love about palliative medicine?
Okay. I'm answering as me. So what I have, I'm not trying to represent the whole of the group that is working in palliative care. What I have loved is the stories about who are these people who you were meeting as they are dying. Who is this person who's coming to this point in their life? I'm endlessly curious about how people have lived and what they've learned during their lives. I think what it brings for me is it brings some of the emergencies and drama of medicine, because I loved that about hospital medicine. I loved a good emergency. It brings those things, not every day of the week, but there is still plenty of emergencies happening. It brings excellent pharmacology, so that you have to know your drugs and how they are handled by failing body systems. That's hugely satisfying. I love having the family around the bed. I really like medicine where the person is part of a family. And I loved that about pediatrics, but it was the only thing I loved about pediatrics. So palliative medicine brings me that. So I think it is the people, how they've lived, approaches to life, the medicine, the pharmacology, the holistic approach. And I think I have loved the opportunity to think about what it is to die well, and how lucky are we who can come to the ends of our lives in medicine, who have seen lots of people die, and to understand how to prepare to have a good death.
That's incredible. That's so good to hear. And I think that honestly, there's so many other things that we could talk about. And it's a shame that we can't have 10 episodes on this, because I think I could keep talking about this all day. But Éabha, Mary, do you have anything else you want to add?
Just thank you very much, because that was really interesting and really great to be able to ask like some really honest questions. Yeah, thank you.
Yeah, I really do appreciate your time. It's been such a joy to meet you. Thank you.
Thank you all. And it's a pleasure to be invited and an honour. Thank you.
Thank you, Dr. Miller. So I think that's all we have time for today. Thank you so much to our panellists for joining us, and everyone at home for listening to this episode of Sharp Scratch. If you like our show, I'd love it if you could support us by leaving a review wherever you get your podcasts, or sharing with the people you know. Tell your friends about us, that helps them find the show. Keep in touch. I'd love to hear your thoughts, your feedback, any trends you find interesting in medicine at the moment. You can find us on social media, BMJ Student, Twitter and Instagram. Sharp Scratch is also on TikTok. You can find us, Sharp Scratch Pod. There you can keep up to date with all of our latest clips. If you'd like to hear more episodes, subscribe to Sharp Scratch wherever you get your podcasts, and in 2 weeks' time you'll be notified of our next episode. Until then, it's goodbye from us.